Yes, sir.
So the host has muted everyone. The co-host and the panelists can unmute themselves. The session will be recorded and put on our Facebook page. The link will also be available to those who are not on Facebook. So let me welcome you to this 91st edition of Thursday Musings. We have a teacher of teachers today. Big catch if I can use these words. Sanjeev Jain sir is there. So there will be a question and answer session with him. Some of our friends will also ask these questions, and Dr. Jain will answer it. Next slide, please. Now, let me hand over the session to Professor Dr. Tofan Pati sir from Cuttack. He is the chairman of the program. Sir, over to you.
Thank you, Alim. And I welcome everyone to this 91st episode of Thursday Musing. Just 9 short of the 100th episode. And we are very happy that we have got your cooperation, inspiration from everyone, all of you. And our two moderators with us are Dr. Halim Siddiqui and Dr. Amrit Patujasi, both of them professor of psychiatry. Halim Siddiqui is the IPS treasurer, and Dr. Amrit Patujasi is the IPS CC member. Young leadership from IPS. And without further introducing them, I would like to proceed on next please. Next. We have a chairperson, Dr. Saranya Devanathan. Thankful, madam, for accepting our invitation just in a short notice. He did medicine from Jikmar Pondicherry, psychiatry from Neyman's, Bangalore. She has been in private practice in Bangalore for 5 decades, 50 years. One of the eminent psychiatrists and past presidents of IPS Karnataka State Bank. Founder President of IAPP Karnataka Branch. Welcome, madam. And our other chairperson is my dear friend, Dr. Mohan Raj. He is MD DNB, MBBS from Stanley Medical College, Chennai, MD and DNB from Neyman's, senior resident at Neyman's from 1992 to 95, PV Subramaniam Gold Medal for Psychiatry in Final MBBS, JRM Award for the Best Research Paper in IPS South Zone in 2000, consultant psychiatrist from 1999 at Chennai, area of interest, preventive psychiatry, public education through print, television, and web, book chapter on protective factors. His YouTube channel is Mindscape Matters, Mananalam, and Nalamiria Aval in Tamil. Welcome, Dr. Mohan Raj, and hence hereafter, everything belongs to you, Dr. Mohan Raj and Dr. Saranya Devanathan. It is over to you.
Yeah. Dr. Saranya will start. Dr. Saranya, ma'am, you have to unmute. Okay. Dr. Saranya will introduce the topic and then I will introduce the speaker. Or how do you want it, ma'am?
No, I will introduce the topic, then you can introduce
then I'll introduce the speaker, yes.
Can you hear me?
Yes, ma'am.
You can hear me?
Yes, ma'am.
Okay. Just the very good topic, and it is a question and answer session so that it looks very nice. We do see patients who come with the positive symptoms like hallucination, and they are treated, positive symptoms become all right, but they are not all right. Their quality of life is very bad, and even they are disabled also because of the negative symptoms and cognitive symptoms. On the other hand, we do see patients who are hallucinating nicely and they are very comfortable. They are working, they are earning, they are doing all these things. So we have, the enigma of schizophrenia. What is it? What kind of things? And ultimately, we have to aim at giving a good quality of life for the person. So let us start discussing and let us answer the questions as much as possible from whatever evidence is available. Over to Dr. Mohan Raj to introduce the speaker who will be enlightening us.
Yeah. 1 second. Yeah, I have had the rare privilege of being Dr. Sanjeev Jain's students. and I'm happy to introduce him. He's been a clinician and a teacher and researches the genetic correlates of psychiatry and neurological disease from the 80s or even earlier. He is a MBBS from Maulana Azad Medical College and subsequently psychiatry in Imams. And he has been a Commonwealth Fellow at Cambridge and the co-director of NIH Fogarty Training and Mentorship Program. He has provided the lead for and participated in several population and cohort studies, and also provides genetic testing for several neurodegenerative disorders, as well as counseling services for these families. His work includes genetics of schizophrenia, bipolar, Alzheimer's, Huntington's, as well as addiction and OCD. He has been a member of the committee for drafting the mental health policy document for India, and is also an adjunct faculty at the National Center for Biological Sciences. His other interests include history of mental health services in India from the colonial to contemporary period, and many of you will fondly remember the sessions in the conference where he will have one genetic session and there will be one history session, both very, very interesting and both lot to learn. He would do along with Dr. Alok sir, the history part. I've always looked forward to those. And I was fortunate to be working under him for 3 months. And during that time, he had taken me to one of the home for the disabled. And one facet of Dr. Sanjeev Jain is an absolute dedicated physician, not an exaggeration. So I won't keep you away from the speaker for long. I look forward to Dr. Sanjeev Jain's talk and the question and answer session.
Thank you, Mohan. And Dr. Saranya, it's a privilege to be here and an extreme pleasure to be sandwiched between a senior student from NIMHANS and a younger student from NIMHANS. So I'm the in-between generation. So thank you very much for this unique opportunity. So now I was prompted to comment on this Voices Come and Go on an exchange of mails in our web chats. So I just said this line. It was prompted by as usual by patients. So a couple of years ago, a patient whose family had been seeing for many years, he's got 2 or 3 relatives with schizophrenia. He came quite happy. He says, voices have stopped. And so I said, what happened? You've been in clozapine for so many years, 10 years, voices had never stopped. So he looked at me quizzically, sir, वो बूढ़े हो गए, वो बूढ़े होके मर गए और आवाजें आनी बंद हो गई. आदमी बूढ़े हो जाते हैं ना, वो बहुत बूढ़े थे तो मर गए. So I realized that so this little, nothing had changed in his schizophrenia, nothing had changed in the rest of his functioning, but this gave rise to a peculiar observation that as patients age, the voices never seem to go old. The voices continue to remain the same. So what is it that causes this stuck quality of voices typically? Is it plasticity? Is it changes in the neuronal cortex? Is it just habituation? Is it just convenience? Is it a psychological persistence with some kind of dysfunction? What causes them? What maintains them? What makes them fade away or go old and die? So all these ideas come up when we look at the biology of or the phenomenology of schizophrenia. So that's why I just happened to quote that, and that interested Professor Siddiqui, and he invited me here. So here I am. So we can take it forward from there.
Sir, thank you so much for joining us. I think it started from the EIPS group when you posted that line, and I just I just caught it and posted it to you.
Yeah.
Sir, so today's topic is devised in a question answer session. Amrit, would you like to start the session?
Yeah, sir has already talked on the topic. It's a very intriguing topic when people talk that we've always been taught about the FRS. So, and auditory hallucinations has been, if you look at the core psychopathology, phenomenology, so we talk about, when we talk to patients, we ask about the auditory hallucinations. Is it there? Is it reduced? Is it distressing? And our treatment is based on the fact that we are able to take care of the hallucinations. So one of the recovery, like if somebody is having a persistent hallucinations and you have managed to take care of the hallucinations, you think that you have taken care of the schizophrenia or the illness per se. But now that you are telling that voices will come, voices will go, but schizophrenia goes on, makes us feel that is schizophrenia something that we have to live throughout the world, throughout our life? Like you told that, so can you please elaborate on these points? So should not be auditory hallucinations being treated be one of the endpoints of our treatment when it comes to this illness? We'll talk about the whole concept of schizophrenia later on.
Right. So obviously the experience of hallucinations is central to our understanding of schizophrenia. Now, Esquirol, way back in the early 19th century, said that hallucinations are not perceptual disorders, they are cognition, they are a cognitive disorder. That people think they are hearing voices, but they are not actually hearing voices because there's nothing in the sensory pathways to show that perception is going on. So Esquirol raised this question way back in 1820. And since then, this whole issue, what is a hallucination? And are people thinking that they're hearing voices? Are they imagining voices? Or are they actually hearing voices? So that question has not been answered from the time of Esquirol. In the recent, 40, 50 years, and actually much longer if you read the Indian census reports more carefully, the prevalence of schizophrenia is slightly higher in those who are deaf. It's 2 or 3 times higher than the general population. But it is not higher in those who are blind. So auditory deficits by themselves seem to increase risk of schizophrenia. And this, according to V.S. Ramachandran, occurs because when you do fMRI of hallucinations, the hyperfunctioning is in the temporoparietal occipital junction cortex, which is highly plastic. The occipital cortex is very fixed. So columnar organization, so it's very tightly fixed. Is not that plastic, but in this plastic zone, the pathology of schizophrenia arises for various reasons. Now, whatever is the biology of schizophrenia, which will interfere with plasticity at particular points in time and is amenable to drugs, will keep fluctuating depending on the load of the biological insult, which can be anything from cannabis to emotions to stress to drug default. That biology will reassert because the fundamental issues that are driving the plasticity, which may be genetic or epigenetic, whatever has happened, do not get altered very much. It is age, time, long-term exposure to drugs that changes the biology and keeps it modified in a particular way. So hallucinations by themselves are one of the many aspects of schizophrenia, but by no means the most important or the most critical.
So, sir, what are the other things that are going on except for hallucination?
Oh, see, if you, again, the classic textbooks of both Krepton and Bloiler suggested that everything goes wrong with schizophrenia, everything possible, from their thought disorder, from attention, from concentration, from use of abstract knowledge to inner speech, to being lost in fantasy thinking, projecting their fantasy thinking to the world outside, loosening of boundaries. So all these have been known. But the issue is that we don't have a coherent biology to explain all the neuropsychological deficits. The one thing we do seem to have some knowledge of is that exposure to drugs of abuse, like amphetamine, cocaine over a long time, produces paranoid psychosis, and drugs like PCP and ergot alkaloids and LSD produce hallucinations. And in the last 50 years, from the 50s at least, when we invented all these drugs, somehow we seem to think that delusions, hallucinations, because we can produce them and treat them, these are the core symptoms of schizophrenia. But schizophrenia is a much older disease with many, many diverse symptoms. So I think hallucinations are just part of that whole spectrum of neuroplasticity that is dynamically changing over a lifespan, and therefore they can come and go. But the plastic changes or the atrophic changes that are going on in the brain of a person with schizophrenia are perhaps a different kind of biology.
Sir, are there things going on outside of the CNS also?
Probably. This is driven by our experience in Alzheimer's disease and Huntington disease. So Huntington disease patients, as you know, have lots of OCD symptoms and psychosis when they are in their 20s and 30s. And gradually, as the chorea progresses, the psychotic symptoms drift away. Most often, sometimes they persist. And even if they live long and avoid deaths by aspiration, etc., because by itself the disease doesn't kill, ultimately they have severe cachexia. And even with Alzheimer's disease, you find that even if they are well looked after, ultimately cachexia happens. So whatever the cellular defects are, now this is, I'm going to vary into extremely speculative biology. So the issue with biological psychiatry, with psychiatry itself, is whatever happens is so subtle that it interferes only with the inner workings of a neuron. It never breaches the cell membrane. It never comes out of the cell, which is why you don't get biomarkers or biochemistry. So the only way to understand biological psychiatry is to understand the inside of a cell, not the outside of a cell. Now that technology we are still developing. So we don't know how to study the inside of a cell very well. So in that sense, these changes, like with dementia, ultimately cells of the brain will die first because they are the most sensitive and the most metabolically active. They use 40% of the body's oxygen. They are high energy things. So they will, in terms of metabolic insult, they will be the first to die. But if the person lives long enough, all cells will die. So ultimately, patients will lose weight. They will have adipocytes, which will start dying because adipocytes are also post-mitotic single cells. They never divide. The number of adipocytes is fixed at birth, like neurons. So ultimately, the adipocytes will also shrink. The muscles will also shrink. So there'll be a lot of muscle wasting. So those of us who are privileged to work in chronic wards, like NIMHANS has a few chronic patients, ultimately you find that they become skeletal. They are getting the same 2,500 calorie food. They're getting the same nursing care, but ultimately they become thinner and thinner and thinner and thinner. So probably there are other aspects of schizophrenia outside the CNS that we also need to keep in mind.
Okay. Thank you, sir. Sir, there is a question. Is there anything actually like schizophrenia? Does this disease exist, or we are just nomenclaturing it? And people are actually clamoring for the abolition of concept. There's those views also. So your views on this aspect?
Oh, I can't even take that seriously, in the sense that madness has been with human beings forever. Every society has defined madness. There is no society in the history of the world which has not defined an insane person. Now, whether you call it schizophrenia or unmada or a brain disease or a dopaminergic dysfunction, we are inventing neologisms and approximations. Schizophrenia word itself is a sandhi viched of skids plus phrenia from Latin. It's a neologism invented by Bleuler. You can even say it's a symptom of schizophrenia itself, a neologism called schizophrenia. But then so is quantum physics, so is a quark, so is iota. The square root of -1 doesn't exist in the real world. We don't want to banish the square root of -1. Our cell phones will stop working if we abolish the square root of -1. So there are conceptual issues in the world which we cannot check with our eyes and with our perception. And they are very valid. These are very valid abstract concepts. None of us can experience gravity. We don't say, let's abolish gravity. So schizophrenia as a concept exists, a madness exists. We have to explain its occurrence. Now, whether we call it schizophrenia or some other disease is entirely our own imagination. But I don't think one can do away with the concept of schizophrenia. This has proved its utility. It's proved its utility in our clinical bedside. The number of patients who are actively helped must be running into millions and millions. So it has its utility. It has its validity. And I don't really see where the criticism, I mean, again, I'll tell you, I went to a conference, I was visiting University of California, Berkeley, and there was a public seminar on schizophrenia, and the speaker was typical liberal West Coast American who said schizophrenia is an oppression, schizophrenia is this, we should ban the word schizophrenia, it's an oppression of a minority, went on and on for 1 hour. And then one patient got up, one young man got up and he said, "Doctor, are you trying to tell me that I've been looking after my brother for 20 years for something that does not exist?" At which point half the audience clapped because most of the family were carers. And they were most upset by this extreme view that schizophrenia doesn't exist because they've been looking after their children, brothers, sisters, spouses who have schizophrenia. And you can't wish it away by changing a name, by making a political grandstand out of it. So I'm sorry, it's a long answer, but I feel quite strongly about it. Sorry.
Yeah, Debabrata has
Good
sent a question. Debabrata?
Yes, sir.
Yeah, please.
Yes. Good evening, sir. My question is on BSNP study, that is the clinical phenotype of psychosis in bipolar and schizophrenia network. What is your take on this study, sir, and how much difference phenomenologically exists between bipolar and schizophrenia?
See, phenomenologically, now this is, as Mohan already mentioned, my interest like both in schizophrenia, in genetics and history. So this debate between whether we have one madness or two diagnoses or multiple diagnoses of psychosis is both a theoretical and a practical question. So I don't know if in our library we had this very classic book by Leonard on the classification of endogenous psychosis. Leonard being a contemporary of Angst and Perez and all that. So he defined 40 different kinds of psychosis, 40. Systematic psychosis, non-systematic psychosis, within that cataphrenias, epiphrenias, motility psychosis, mood disorders. There were 40 different kinds of psychosis, which are reduced in DSM and ICD to 2. Schizophrenia, bipolar disease, following Emil Kraepelin. Now, whether Leonard is right or whether Kraepelin is right, it's all in the last 60 or 70 years. It is too soon. When Chow En-lai was asked, what do you think of the French Revolution? He famously said, it is too soon to tell. So schizophrenia, bipolar disorder, it is too soon to tell whether they are separate diseases, especially from the genetics point of view, like the BSNP studies and much of our work. So we do not, nowhere in the world have you been able to differentiate successfully the two syndromes. So there's a huge overlap in the genetic risk markers, whatever it is that we know, the 1,000-odd markers that we know, seem to overlap a lot between bipolar disorder and schizophrenia. On the axis of severity and psychosis, presence of psychotic symptoms, they differentiate slightly. That those with psychotic symptoms in bipolar disorder tend to be closer to those with schizophrenia than the run-of-the-mill bipolar disorder or bipolar 2. So it is the psychotic experience which seems to be linked to more amount of genetic sharing. And that is also shared with Asperger's and with autism. So perhaps there is a core of neuroconnectivity plasticity that predisposes a person to unusual patterns of thinking and experiencing things. And then the mood disorder or bipolar disorder, schizophrenia is one other aspect of this. Now, that's what the genetics is telling us. But genetics may tell us something else entirely 4 or 5 years from now. So I think genetically there's a huge amount of overlap. We know phenomenologically there is a lot of overlap. We see it in our own files. We've been following our families for 10, 20 years, and the diagnosis does keep changing. If you follow Kraepelin's definition of deterioration, 10% or 20% of bipolar patients will deteriorate and have a chronic illness or a chronic deficit state. So the deterioration is also there in bipolar disorder, which we don't recognize. Kraepelin famously never put mood into any of his symptoms. He just put deterioration and cyclicity. So if you use Kraepelin's definition, the two syndromes also overlap.
Okay.
Thank you, sir.
Thank you,
Sir,
Devabrata.
you said something about,
Dr. Minhas.
yes, sir. You said something about that we look to see in the cell, not outside
Yes.
the cell.
Yes.
And what is this ADBS study and its implication in current psychiatry?
So that's what that's what we are trying to understand. See, current technologies allow us to create or reprogram peripheral cells into neurons or glia. So we can take a cell from a fibroblast, from a skin punch, or from the blood, and we can convert them by using certain viral factors back into being a stem cell. And by reprogramming that, we can convert them into dopaminergic neurons, serotonergic neurons, cholinergic neurons, striatal neurons, neocortical neurons, hippocampal neurons, etc., etc. And if you co-culture them, many of these cells together, you can actually get a miniature brain, which will be about an inch in size, but it will have neurons, it will have glia, it will have synapses, it will have almost all the biology that we expect in a working nervous tissue. This can be produced in about a year. Starting from day one, in about a year, we will have a culture of cells which even look and behave like a brain with a small ventricle inside. Now, by taking cells from here at various stages, you can study an individual neuron, you can study their synaptic organization, you can see how circuits are made, and that is what will be done over the next 10, 20 years. But everything points to the fact that the biology inside a cell is quite different. So for example, we looked at mitochondrial potential in cells from bipolar patients, and it's very different from normals and gets normalized by giving lithium. We look at how cells divide, at the rate at which they divide, and that is slightly abnormal in bipolar disorder at the baseline. And by giving lithium and valproate, we can correct that cell cycle abnormality. And those who are non-responsive to lithium don't show the response to lithium, it gets corrected by valproate. And this is all changes in the way cells divide and maintain themselves, individual cells. There's nothing to do with the circuit. Every cell of the body is behaving like this. So the changes that we are producing inside a cell, not at a circuit level. So we need to understand how cells respond to these drugs and how long they live, how they die, how they replicate, and therefore how neurons and glia produce plasticity by themselves.
So I think then we have to change our perspective. Instead of seeing a patient, we also think about the cells and the circuits, that is things that are going on.
Well, I've been campaigning for some time at NIMHANS to start at least a PDF or a DM in molecular psychiatry, because I think that is essential for the, once these genetic researchers progress beyond a particular limit, and I can give you examples from our clinical work. So we published a paper, I think in the IJPM only recently, on a person with a very rare mutation. Started with hallucinations, typical late onset paraphrenia. 45 years, starting hallucinations, delusions, infidelity, and then very gradual memory deficits. But giving a small dose of risperidone, she went into severe EPS. So that was unusual because we know, and sensitive to antipsychotics is like Lewy body disease. So we investigated more thoroughly, and we found a rare mutation that can cause a dementia and psychosis-like picture. Now, the phenomenological diagnosis is one thing. We can't change that mutation, but at least we understand what aspect of cell biology could be contributing to this psychosis plus dementia. We had a couple of cases, and again, part of them are reported in Asian Journal of Psychiatry and in movement disorder journals. So young onset Parkinsonism with a homozygous variation in a particular enzyme, phospholipase A, starts with depression, hysteria, schizophrenia, and then rigidity, and etc. So first 4 or 5 years are just academic decline in a young person, psychiatric symptoms, hallucinations, and then progressive EPS and death. But it's a PLA2 phospholipase A is a very interesting gene. It controls lipid turnover and vesicle formation. They are exquisitely sensitive to antipsychotics, went into almost akinesia or catatonia with a small dose of haloperidol or risperidone. But then we discovered that these drugs inhibit phospholipase. All antipsychotics also inhibit phospholipase, and they change the lipid constitution of vacuoles inside a cell. It's not merely dopaminergic blockade that we are talking about now. They are producing changes inside a cell. And in schizophrenia, PLA2G levels change. These antipsychotics have a metabolic action, and perhaps that also explains some of their action. The metabolic inhibition of PLA2G6, which in people who carry a mutation can be absolutely lethal and cause, akinesia completely. But in others, they just get EPS. Many of the genes we implicate in Parkinson's disease are metabolic genes. Synuclein, Parkin, Pink, none of them are dopamine or receptor linked genes. They are metabolic genes. And we know the interface between dopaminergic receptor blockade, Parkinsonism, and schizophrenia. So what we think simply as dopamine blockade is only a very small fraction of the issue. Dopaminergic sensitivity is controlled by metabolic actions, information signaling, and the synapse. Till now, we've got the low-hanging fruit of Seaman graph and dopamine binding, dissociating, rate of dissociation. That is the first low-hanging fruit. Uske baad kya hota hai, what happens inside the cell is much more complex. So we have to change our perspective. There's no doubt about that.
Thank you, sir. Sagar?
Yes, sir. So I have a question that, is there any gene for psychosis, or is there any gene for psychiatric disorder? Can you give me an estimate of the number of genes involved, or should I think that all the genes that are in human being are causing this psychiatric disorder, sir?
You obviously can get a philosophical answer and a technical answer. So genes as we understand it now at present. So we have around 20 to 25,000 genes approximately. But all mammals have the same number of genes. A mouse has 25,000 genes, a rat has 25,000 genes, a monkey has 25,000 genes, mutton has 25,000 genes. So there's not much difference in the genes between mammals, number one. What differs, if at all, is the way genes are regulated. Now, at the current modest estimates, there are 2 or 3 different kinds of schizophrenia. One are highly inheritable, like autosomal dominant dementia or Huntington disease, psychosis occurring in them, which may be rare variant disorders, like this phospholipase mutation. So there may be some very rare conditions in which genetic testing can reveal, even at the current level of genetic technology, 1 or 2 genes that may be important in schizophrenia. Cumulatively, they may account for 1 to 2% of all cases of schizophrenia. Especially in families who have multiple members with schizophrenia. But they are important entry points into understanding the biology. The vast number of genetic factors that we're talking about are probably common variations. At the moment, we get about 1,000 loci hits around, which are supposed to, in a polygenic risk score, contribute to risk of schizophrenia. But the area of the genome covered by this polygenic risk zone can be anything between 10 to 15,000 of our 20,000 genes. So almost half to 2/3 of our so-called genetic genes may have variations that may be part of a network that will ultimately cause schizophrenia. Now, the issue is finding genes is one thing and discovering networks is another thing. So how do we understand the networks? Because finally, it's a final common pathway. Everybody will develop, or most people will develop delusions, hallucinations. They will have early synaptic burnout. The number of synapses per neuron will die. The synaptic density will fall. And synapses will not be replaced at the speed and in the place that they should be over time. That is the basic biology of schizophrenia. So ultimately, it's funneling down to a very limited kind of biology. There may be hundreds of factors, but then we must realize that a synaptic vesicle includes 250 plus proteins. Any one of them can impair synaptic vesicle functioning. 250 different proteins make one vesicle, and another 500 proteins make the postsynaptic receptor. People have done a study of these 1,000 genes involved in synaptic vesicle release and binding. The risk of schizophrenia, variation in these 1,000 genes occurs 4 times more commonly in schizophrenia than other genes. 4 times. So obviously these 1,000 genes carry some aspect of biology of schizophrenia, only in terms of synaptic vesicle release and binding. just one biology. So we need to understand the mechanics of this much better. So it is
I'm
likely.
happy.
Yeah. Sorry, you're happy?
I'm happy we are recording the session because I'll have to play it for 1 minute, then wait, then imbibe the knowledge, and then move forward.
No,
So thank you.
these are speculations.
So another question comes in my mind. Can I ask? Can gene therapy can be of any help in schizophrenia? Maybe later on in coming years, if not today.
Again, questions can be answered on 2 or 3 different levels. One is, first we have to discover a gene. Now, I can keep going back to Huntington disease because we discovered the gene way back in '93. We still haven't been able to develop any gene therapy because Huntington disease is so critical that to switch it off causes immediate death. So you can't switch the defective gene off. You know it is a mutation, you know it's causing a problem, but you can't switch it off because there are networks that we don't know. You can put small interfering RNA to shut down the mutation gene. But by the time you're doing it is after the patient has come to you for treatment. The gene has already changed the brain for the first 40 years. You can't go back in time. So the only way to prevent this would be to either do the gene therapy at birth, provided you knew what genes were involved, or do other things. But the more reasonable thing is to discover the networks and find small molecules that can repair the networks. And actually, much of the treatments that we do are gene therapy in a way. Because what happens when you give chlorpromazine or risperidone or whatever drugs we give, the neurotransmitter blockade occurs within seconds. But recovery takes place after 2 weeks and it continues for 12 weeks before you can say it is drug non-responsive. So between the milliseconds of the drug action on the synapse and 2 weeks to 12 weeks of recovery is a large amount of time. And that's where gene regulation is happening. Genes are being switched on, off, altered, metabolic pathways are being changed, membrane excitability is changed. That plasticity takes for 3 months to occur. And that is all gene regulation which is happening. So we have to understand these processes, how the common drugs that we use are actually changing gene expression patterns. We've done this in rats, we've done this in cells, and there are many. So people have done gene expression with various antipsychotics, try to discover what is common between clozapine and the other drugs, what is unique about clozapine, and there are very significant differences in the gene transcripts following clozapine versus other classes of drugs, where the genes are being changed, which part of the brain they are changed, are they changed in neurons or astrocytes or glia in the same way? So we are learning a lot from all this. Colleagues of mine are doing a whole lot of studies on this, both at NIMHANS and in other labs all over India and the world. So we will get to know more. But I think small molecules, one should not discard them. Gene therapy sounds very exciting, but it's a nightmare. How do you deliver gene therapy to the brain? You have to go in with surgery and insert retroviruses. It's not easy for a psychiatrist at the moment. Of course, we may resume our neurosurgery postings and then we may also learn neurosurgery, but at the moment, no psychiatry training offers neurosurgery.
You may be also merging the branches then, sir.
Absolutely. Absolutely. Anyway, the separation is more recent than the word schizophrenia, so perhaps it is as much of a delusion like schizophrenia itself.
That is why neurosurgeons are treating psychiatric patients now.
So anyway, it's merging.
Dr. Shobit is next.
Yeah. Good evening, sir. So my question is, like we all know now that psychosis is a symptom, and it is because of some cryptic genetic defect.
Right.
And so we are giving antipsychotics, and we know that they would definitely work in psychosis. Then the dopaminergic hypothesis came. So my question is that whether the other psychotropics also can help us in dealing with the psychosis apart from antipsychotics, citing, like you have also cited an example, many patients are very sensitive to very small dosages of antipsychotics. At times we take them off from antipsychotics put them on very minute anxiolytics, they perform better. Surprisingly, the psychosis is taken care of. So your
So you've touched on a very, very interesting topic. Now, over the last couple of years, people have begun to realize that many neurons actually secrete multiple neurotransmitters. So dopamine and glutamate are often released simultaneously and from the same neuron. And they serve an inhibitory control on each other. So dopamine, as we know, is mainly an inhibitory neurotransmitter. So it also controls the amount of glutamate release. And as we get to know more about the precise pharmacology of these drugs, there may be ways in which you can influence the cocktail soup of neurochemicals that are being released at various points in a more fine-tuned manner by a judicious mixture of various neurotransmitter simulators, blockers, reuptake inhibitors, etc., etc. So I think there is a big scope. There is a considerable scope for making drugs, for making new drugs driven by the biology that we are beginning to understand. Whether it's vesicle transport, whether it's the surface receptors or reuptake, we should be able to combine. See, anxiolytics basically are binding to one of the pockets of the 5 components of the GABA receptor. The benzodiazepine receptor sits inside there. So that is itself going to alter because in the brain, many of these receptors occur as multimers. They don't occur as single. So there are rafts. So that is going to, how it is going to link up with the dopamine receptor and thereby change its activity may well be doable by judiciously designing new benzodiazepine analogs or new glutamatergic analogs, which can also regulate the dopamine receptor. These drugs had been talked about 10 years ago when they were trying to make drugs which would simultaneously block glutamate and dopamine receptors, both being GPCR, the GPCR kind of NMDA receptor. But in real work, and it never got into the market, but there were a number of papers published on how to design new drugs that will bind to multimeric or dimeric receptor proteins. So there is a lot to be learned from small molecules. I don't think we have finished with them yet. We finished, like I said, they're low-hanging fruit. From the base chlorpromazine molecule, we made 100 drugs. But it's time to look at new molecules and invent new drugs.
Thank you, sir.
Yeah.
Thank you. Archana.
Sir, good evening, sir. So continuing with the previous question, can we justifiably give drug the names as of antidepressants and antipsychotics and things like that, or we need to have something more, devise some more means and mechanisms for that?
Well, as you'll realize, I'm much older than many of you. So when we started all this, they were called thymoleptics and neuroleptics and all those kinds of names, which are now the dustbin of history. Except that thymoleptics has changed into antidepressants, just made it more simpler. But I think pharmacological names are approximations, and I don't think they mean anything in real life. For example, if you look at at other literature, chlorpromazine potentiates anti-cancer effects. It improves outcome in glioblastoma. It is a profound antibiotic. It is used in drug resistant. It is being experimented with for control of multiple drug resistant tuberculosis. So the multiple actions of chlorpromazine on biology, right from mycobacterium to glioblastoma multiforme to breast cancer and schizophrenia, we do not have a model to synthesize all this together in one biology right now. So to think of chlorpromazine as purely an antipsychotics is probably a fallacy. It's just a historical artifact that it was used as an antipsychotic first, but I don't think it is just an antipsychotic. For those of you who remember, the first chlorpromazine was called larzactil for the large number of actions. So we have hung on to dopamine for our own overvalued ideas, but that may not be reality.
So Dr. Nandini Chakravarti has raised her hands. Dr. Nandini, you want to ask something?
Welcome, ma'am. Please go ahead.
Thank you. Thank you. I just had a question for Professor Jain. Been really enjoying the session over here. Two questions, sir. So, is there any genetic research going on which will help us distinguish between what presents as first episode of psychosis in schizophrenia versus acute and transient psychosis? That's one question. I mean, extending from there, the studies have almost consistently shown that 20 to 30% of people, even with a diagnosis of schizophrenia, come off medication, remain well, but the vast majority will need medication. Almost 85%, let us admit, will relapse within 5 years if we take them off medication. But for the small minority who might come off medication, are there any genetic studies going on? And my second question is, do we have any genetic studies to predict which medications people might respond to? Because right now we do a lot of trial and error. Is there somewhere we can cut that down and know what to prescribe based on genetic trials? Thank you.
So this acute and transient psychosis is clinically a very troublesome issue, because despite the ICD and DSM, different parts of the world diagnose it quite differently. And so we really don't know what acute and transient psychosis actually mean. I mean, in the sense that they're a mixed bag. So how brief should it be? 2 days? Should it be a micropsychotic episode? Should it be 2 weeks? DSM-3 hallucinations had to persist for 6 months before you could diagnose schizophrenia. DSM-4, they removed at 6 months. So patients who have first-time symptoms for a month, are they schizophrenia or are they acute? I mean, these are clinical questions which we haven't answered. We also know that a whole lot of cultural factors and other medical factors that can be at the root of acute and transient psychosis. Classical issues being infectious disease, zoonosis, toxoplasmosis, various arboviruses. So psychosis can occur as a cryptic manifestation of infective disorders. There are nutritional issues, vitamin B12 deficiency, folate deficiencies, things like that. There are endocrine issues. So many times you discover that till you correct the thyroid, the psychotic symptoms don't disappear. So they can be, and once you treated the thyroid, the psychotic symptoms never come back. So how many of the psychosis that we are seeing are actually manifestation of underlying systemic disease? Nobody has ever actually measured that, because for the last 40, 50 years, the non-psychological underpinnings of psychosis have not been studied. We've looked at basically expressed emotion, culture, and faith and all that, but we have not looked at ESR and infection and TLC count and done blood cultures and virology studies. So, for example, we are trying to write a paper when colleagues of mine so we looked at autoimmune markers in about 400 patients over like 3 years. Patients where we don't really think is just schizophrenia. So we keep on investigating. Out of the 400 people that we investigated for autoimmune disease, about 50 have turned out positive. So which is about 10% of non-typical schizophrenia. And that's non-typical is governed entirely by the clinicians. That this doesn't look like the rest of schizophrenias. There's a fever, they're not responding well, there is some joint pain, there is something else. There's something vaguely upsetting to us. So in 10% of those is actually autoimmune disorder. About half of them improved after we gave steroids. Full stop. Now, how aggressively we should investigate acute onset schizophrenia, therefore, remains a big issue. So acute onset psychosis should be investigated just like we do with adult onset psychosis, where it is organic till proved otherwise. I think acute psychosis also should be investigated with the same degree of rigor, that you rule out any other systemic cause, infectious, metabolic, endocrine, structural, etc., etc. And only if it doesn't fall anywhere into that, then you think of it as a schizophrenia illness. And by the time you do all the investigation, anyway, it'll be a month before you get to all the reports. So the time thing is also solved. But that doesn't take away the fact of buffet delirante and the acute confusional episodes which also occur. So I really think, so nobody's been able to collect a big enough sample of acute psychosis in a consistently defined manner. So genetic studies don't exist. And they can't exist because nobody is collecting these samples. So we are in a dead end about this. Coming to your second one about pharmacogenomics, we tried that about 10, 15 years ago. And people have done that for quite some time. And it was commercially available for a few years, and I think it still is. But basically, people look at metabolizing enzymes, CYP2D6 or some serotonin receptor variations. But basically, it's metabolic differences in the rate you metabolize both SSRIs and antipsychotics, which varies a lot by ethnicity and by genetic makeup, can interfere with blood levels. But the actual clinical implication has been very minimal, because metabolic rates have very little to do with brain biology. Less than 1% of the chlorpromazine of antipsychotics that we use, because they are protein bound, go into the brain. So for every 100 milligram of clozapine, less than 1 milligram is going to the brain, and about a millionth of that is actually acting on the synapses. So between metabolic levels and the site of action is a difference of several thousand-fold, and we don't have the technology to study that at the moment. Till we know the complete biology of these drugs, we won't be able to, and then interface with all these large studies. So that's why Vietnam has wanted to set up a center for longitudinal studies. So it's only when you match the genetic makeup of the person with outcome over a year or 2 years, will you know what predicts recovery. And to do that, you have to maintain patients on follow-up. So unless we develop a system of looking after patients for a long time, we won't be able to answer that question. So we really have to develop long-term care for the mentally ill, for the severely mentally ill. Only
So, sir,
then
are we
we
shooting
can
in the
answer
dark
these
then?
questions. Right now, we are
Partially, at
shooting in
least.
the dark.
Mhm.
That's again a historical fact. The first drug to use in psychiatry was Sarpagandha from Calcutta, which was a vesicle reuptake inhibitor. 20 years later, they invented a synaptic blocker. After that, we have not invented anything. So between 1930 and 1950, we invented 10 drugs. 1950 to 2020, we have not invented a single new drug. And that is the fact of the matter. So,
Sure. So there is an effort of classification known as NBN classification, neuroscience based. So
yes.
What are your views about it? It is an also ran thing, or it is
No. I don't think it's an also ran thing, but I think it is shooting above its weight. We don't know enough neurobiology. So what you think of neurobiology at cartoons in Stahl's excellent textbook are actually cartoons. They are what we understand of neurobiology now. So there is no point pretending that we know a lot more when you don't actually know a lot more. We don't know how dopamine, years ago as a student, we had wondered about teratology. And synapses have to develop with connectivity. So, okay, antipsychotics don't cause teratogenesis, but they will block D2 receptors in the fetus. So where will the incoming dopaminergic neuron identify a dopamine receptor? Because it is already blocked. So will the children have dopaminergic deficits, etc., etc.? But then we realize that D2 receptors appear only after birth. They're not created in utero. They are created only after birth. So, okay, lactating mothers, if they are secreting chlorpromazine, will change the dopamine functioning in the basal ganglia. So we did a whole lot of experiments on rats, and they produce deficits and they don't produce any change. So because unless we understand how to study the subtle changes in neuronal connectivity produced by blocking dopamine receptors when they are being created at birth, we will not understand all these actions. So we have to understand neurobiology at a very, very big scale, that's why they have the Decade of the Brain Part 3 now. Decade of the Brain 1990s, and another one in 2000, and another one has started, Decade of the Brain. Because the Americans say first we have to invent the technology to study the brain. Only then we can think of answering. Right now, we're in the phase of technology, not in the science.
Okay. Ganesh, are you up?
Yes, sir. Yes. Yes. Hello.
Yes, I can hear you.
Good evening, sir. Myself,
Good evening.
Dr. Ganesh Shankar, sir.
Sure.
My question is related to EPI clinic, early psychosis intervention clinic. Sir, many of the hospitals, they are running the EPI clinics where we see the cases of first onset psychosis or prodrome of psychosis. Sir, I would like to know how effective these clinics are as far as the diagnosis of early psychosis is concerned. Sir, do they really represent the psychosis with fidelity? Because in the any major brain dysfunction that can present in the very early phase as psychosis.
Sure. So I think you partly answered the question in your rider question. So first you have to rule out whether it's another brain disorder. That's the most important. But just like you have a golden hour in cardiac disease and neurosurgery, trauma injury, I think in psychiatry, we also have to come up with the time of the golden months. That the most effective treatment of psychosis, technically, is the first 5 years. Whatever changes you can make in the plasticity and the way the brain is going to program itself to recovery will occur in the first 5 years after diagnosis. So whether it is a primary level of drugs, whereas the secondary level of psychotherapy, whereas the third level of improved social skills and making sure skills are not lost by isolation and by stigma, all these efforts have to be put in that golden period of 2 to 5 years. After 5 years of illness, your bang for the buck will keep dropping lower and lower. But if you can successfully manage all this, just like with cardiac events or by head injury, early enough, quick enough, effectively enough, long-term morbidity can be reduced. So we really must go all out for early detection and appropriate, adequate treatment in all modalities, not just drugs. Because the deficits of schizophrenia are also in the social space and in the psychological space. They may be neurobiological in origin, but their impact is in that space also. So changing that space if necessary, or like any disability, helping people function with that disability should be an integral part of planning for recovery of schizophrenia from the beginning, especially in the first 4 or 5 years. Whether the first episode of psychosis is actually schizophrenia or not, we cannot say at this point in time, because I think we've already discussed this. There are lots of issues. But once you're reasonably sure it is schizophrenia, one should treat it in that way.
Thank you.
Thank you, sir. Ritvik.
Yeah. Sir, I had a question about the clinical spectrum, basically. Whenever we look at schizophrenia, we tend to see that there's a lot of challenges and differences between patient to patient.
Yes.
And we have made a lot of clinical types as well as high risk like types that we look at. Do these have any validity in the long term? Like, do we need to restructure the diagnosis, the clinical diagnosis of schizophrenia?
I think that will be a constant refinement. So, but again, one has to see that with a pinch of skepticism. So this morning when I was on rounds, I had a patient who's a young student, the first episode of perhaps mania. He likes mathematics, he likes physics, and he wants to discover the grand theory of everything, which can explain gravitational forces and electromagnetic forces in one. A reasonable aim. Einstein tried it. So he thinks of himself as the second Einstein, perfectly valid. He's got 95% marks in his POC, and he's joined a good physics department. So no problem with that. So I was telling my residents that if you go to the picture of the Solvay conference, and I actually brought up that slide, Solvay conference is a meeting in 1927, in which I think 12 people got the Nobel Prize, either before or after It had Einstein, Heisenberg, Max Planck, Kurt Gödel, Dirac, Curie. Now, Madame Curie went through depressive episodes. Albert Einstein's son had schizophrenia. Heisenberg's son and grandson had schizophrenia. Kurt Gödel died of schizophrenia. So if you define schizophrenia as a dangerous disease, then we should not and eliminate it. We would have been less 12 Nobel Prizes and half of satellite technology and definitely no semiconductors. Because Josephson, who invented the semiconductor, also had lifelong schizophrenia, as did Hans Berger, who invented the EEG. So the point I'm trying to make is that although we think of endophenotypes, we must be very careful that endophenotypes may actually be valuable. The endophenotype of having a crazy thought may actually be valuable. It need not be a disease. And the sum total benefit of endophenotypes may actually be more critical for human beings than the few people who develop schizophrenia. So that's the way that we are trying to understand the evolutionary paradox of schizophrenia. Why is a disease which we think is severe persist at an unaltered rate across all human populations? Evolution should have selected it out. I mean, plague killed off, we became resistant to plague. Cholera comes, we become resistant to cholera. COVID comes, we become resistant. How come there's no resistance to schizophrenia? There's no human population that has developed resistance to schizophrenia. So perhaps it is serving some purpose in the background. So endophenotypes, therefore, what we call high risk, may actually be positive also. The Scandinavians did a study years ago in which they looked at family aggregation of high functioning individuals and families of mentally ill, because they had the data. And they could detect that many families with mental illness also have very high functioning relatives. And that balances the cumulative social distress caused by the illness. So,
sir, is this issue of resistance related to communicable versus non-communicable diseases?
It makes no difference. It makes no difference. Sickle cell disease and malaria play off on each other. One is an infectious disease and one is a non-communicable disease. Biology is biology. We are part of the biology of the world. We are not unique from the world. So we are the infections to some other animal. We must remember that. We kill, I think, a billion chickens a year. Every month, sorry, not every year. Every month, 1 billion chickens are killed and eaten by human beings. So we are probably a disease for them.
Great insight. Great insight. Paramveer, you want to ask a question?
Yes, sir. Good evening, sir. Sir, my question is regarding the negative and the cognitive symptoms of schizophrenia. Right. What would you say are the current most robust pharmacological agents that we have which may help in improving these symptoms, and are they actually effective? The second part of the question is, sir, are there any drugs for these particular symptoms which are in development or pipeline? And if so, if not, and if they will be developed in the future, what particular area of the brain or transmitters or cellular mechanisms should be targeted to improve these symptoms?
So going backwards, that answer will come only when we understand what is going on. So till we do that, it's one issue. The other thing is, and this is again something that we keep discussing in rounds and in group discussions, that in many ways it's like diabetes. Now, controlling blood sugar is one thing, but being able to change the rate of progression of neuropathy is a different thing entirely. Even in well-controlled diabetes, neuropathy can develop, retinopathy can develop. None of the drug treatments for diabetic control very much alter the risk of retinopathy or neuropathy. Does that mean that we don't treat the primary diabetes at all? That would also not be correct. Just because we don't understand how diabetes produces neuropathy completely does not mean we should not treat the diabetes as one thing and do whatever we can for the neuropathy. B12 supplements, regular exercise, avoid injury, make sure you wear special footwear. That's social manipulation, that's psychotherapy, that's rehab efforts. If you can do that for diabetes without much of a problem, why can't we apply the same model for schizophrenia? that sometimes you may need the psychological equivalent of padded footwear. You may have to avoid psychological injury, just like you avoid physical injury with diabetic foot. So the models may be metaphorical, but as doctors, we can apply similar principles quite easily. We don't need to know the precise biology of every component. You know, it was, this was taught to me way back in Maulana Azad, when we asked, why does clubbing occur in mycobacterium, in tuberculosis? They said, we don't know. We actually don't know the biology of clubbing. But we know it occurs. And for most practical management, that's good enough. So the fact remains that nobody can explain till now why clubbing occurs, other than some complicated theory of how inflammatory responses and the way a mycobacteria uses blood vessels or promotes blood vessel growth. It changes the biology of stem cells and the whatever. But we actually don't know. So I think schizophrenia is like that. Now, the specific drug treatments of all the clinical evidence, clozapine seems to be the most effective. About that, there is little doubt. But whether the effect persists over a lifetime is a different issue altogether. So because, again, we have patients in the closed ward who have been on clozapine for years, but whether it's institutional neurosis or this or that, we have not been able to prevent their gradual deterioration, although they have been adequately managed and adequately controlled. Of course, if you stop clozapine, the symptoms worsen. But whether the negative symptoms have improved is slightly, let's say it one way, the effectiveness of controlling positive symptoms for antipsychotics is much higher than of negative symptoms. Negative symptoms seem to require drugs plus a lot of other factors. And that's why, that's all one gets here at the moment.
Nachiketa.
Yes, sir. Hello, sir.
Go ahead.
Yes.
Good evening.
Hello, good evening, sir.
So, as we have understood so far, and continuing from the last point, we do have neuroprogression in psychosis. So, how do we stop that or retard that? Because if our drugs can do that, they are disease modifiers and not symptomatic treatment. And secondly,
right.
If our drugs work that way and they are disease modifiers, so how long do we continue them?
See, one must. So one of my favorite scientists is Eric Kandel, who got the Nobel Prize way back in 2000, and he's a trained psychoanalyst and got 2 Nobel Prizes, I think, or 1, I forget. But so he makes. So I'll jump between Kraepelin and Kandel. So Kraepelin was once asked, how do you prevent schizophrenia? High risk. And his one-line answer was play football. Now, play football was not, I can see Ranjan smiling, he probably loves his Mohan Bagan and the football passion. But the idea was that neuromotor skilling and social communication, which is necessary for a team sport, will actually help prevent schizophrenia. If you can make sure social skills are developed and neuromotor skills are developed, perhaps the impact of schizophrenia, it's the equivalent of fitness reserve that we talk about in cardiac disease. To build up a psychological reserve is very, very important. And even while recovery, the concept of psychological reserve, by providing an enriched environment, by providing enough social stimulation, by providing adequate nutrition, adequate exercise, all this becomes important in regulating neuroplasticity. Colleagues of mine at the NCBS, when they were looking at rat models for depression, could show that by making the cage filled with more toys was as effective in reducing depressive symptoms as fluoxetine. There was no difference. And the 2 added were better than either one alone. Simply by providing toys to the rats, you could change the plasticity of the rat brain in a way that was consonant with what happened with antidepressants. So changing the environment, providing more meaningful interactions is as much of a biological consequence as drugs. So we must understand that everything a psychiatrist does, how they talk, how they behave, what they advise, is also biological psychiatry. There should be no difference between them. So that's my short answer to this. So the neuroplasticity, one should not say occurs only because of the drugs. It occurs by the entirety of the psychiatric care.
So we have to tap into the placebo effect of the psychiatrist.
It is not a placebo effect. It is not a placebo effect. See, placebo effects are very interesting by themselves, and they occur in animals also. They occur, you can give placebo treatments to your dogs, to your cats, to your horses, to your cows, and they work equally well. So same proportion of animals show a placebo response as humans do. So there is something about the interaction with another sentient being, with another brain, that produces these actions. It could equally well be oxytocin. It could equally well be so-called caring hormone connectivity, which happens when people talk to each other. So we should not, so placebo is a very important effect, but I think that also is a biological effect.
Absolutely, sir. Sayam is here?
Yeah.
Yes.
Am I audible, sir?
Yes.
Yes, please.
Sir, you mentioned about the neuroplasticity. So my question is regarding the importance of BDNF in schizophrenia. And are there any other growth factors which deserve a mention except for BDNF? Or are we just giving undue importance to BDNF in schizophrenia?
See, so our interest in BDNF started basically with the genetic variations. So there's a val-met variation in the BDNF gene, which modifies the amount of BDNF released, and it can vary by almost 50% in those who carry one variant versus the other. And therefore it was thought to influence neuroplasticity, or at least treatment outcome in schizophrenia. So about 15, 20 years ago, we looked at BDNF, val-met, whatever the prediction was. And the frequency of the val-met allele differs alarmingly across the world, number one. So genetically, it didn't seem to correlate very much except with ethnicity, not with the risk of schizophrenia, not with outcome in schizophrenia. So genetically speaking, it's just one of the many factors. Chemically speaking, BDNF is obviously a very important factor for regulating neuroplasticity. But that's also because we don't know all the other factors that drive neuroplasticity. This BDNF is a measure that we can assess easily, but we cannot even measure the other peptides which are brain specific, cholecystokinin, various other small peptides which are there in the brain, which have very different functions, enkephalins, endorphins. We have no way of measuring them inside the brain. So what is the actual signaling for maintaining neuroplasticity? We don't have an accurate idea. BDNF is again like one of the, it goes up with many things like exercise, with various drugs. It does change over time. So it does seem to be an important factor, but by no means should we think of it as the only factor. That's all. And it's likely that, as research accumulates, it will become one of the various, one of the factors that underlies this. It's important because many drugs seem to converge on it. Antidepressants, antipsychotics, all seem to use BDNF. Alterations are produced by many classes of drugs. So obviously is something in that, but whether it's all that critical is still a bit of a question, at least in my mind.
Thank you, sir.
Thank you, sir.
Thank you.
Manasvi is here?
Yeah, I'm here. Sir, although we touched upon the topic of gene therapy, but still I can't resist from asking that, can we do is risk modification by vulnerability reduction or resilience enhancement by genetic manipulation, sir, in schizophrenia?
See, I don't, what kind of genetic manipulation can you do in a fully formed human? Okay, now one can think of, so there are science fictionish kind of scenarios. One can now produce nanoparticles which have retroviruses, which can identify dopaminergic neurons and go and insert themselves in the genes of the nigrostriatal pathway and increase dopamine output. This technology has been around for 20 years and has been trialed. So you can put a CSF injection, nanoparticles, viral coated, the viral, like all these viruses, like COVID, they'll recognize epitopes on the nigrostriatal pathway, insert themselves, take over the DNA there and replicate, and you can put a tag of increasing dopamine production. The problem is that once you put it, you can't switch it off. You can't regulate it. And dopamine, as we know, so many of the patients ended up developing hallucinations. They were producing too much dopamine. And you could not switch it off and you could not regulate it because you don't know which genes to put to regulate the dopamine output. So, so you understand, what we think as a simple fix creates more problems till we understand all the steps involved. If you actually can identify a single gene at risk, for example, I gave you right in the beginning of Huntington gene, you can't switch it off because the patient dies. You can't modulate it because something else happens. And ultimately, it's an orchestra of chemicals and connections. So who will define what should be the right orchestra? Kaun Rag Malkaus gayega, kaun Bhairavi gayega? Who's to decide that? So it becomes a problem. Who will decide what the appropriate brain connection should be? Who will decide what resilience should be? That's even if people are debating the nature of schizophrenia, imagine the discussion about resilience. So
that means we have to revisit the concept again.
We have to revisit every concept again. That's what science and medicine is about. We started battling COVID by banging on pots and pans. Then we want immunization. Then you want COVAX. So which was correct? Banging pots and pans or making vaccines. So you have to revisit.
And I think Amrit and myself have to revisit the books, I think. Amrit?
All of us have to revisit the books.
I had never visited, now I have to start visiting. So we have Ranjan, Dr. Ranjan Bhattacharya also.
Thank you.
By the way, Ranjan,
Nice to see you.
Yes.
Kerala has become the center stage of football now.
Yeah, such a fascinating session is going on, sir. So much insightful session, sir. And I'm really privileged and honored to share a session recently in the International Association of the Social Psychiatry, where sir had given me an opportunity to talk about the role of development of Bengal provinces. And it's a wonderful book, sir. The psychological impact of the partition in India. You have written.
Sorry.
You, Alexarin sir, and Anirudh Kala sir has done a real amazing thing. Sir, my question is that, sir, regarding we have seen in our chronic institutional setup that the patient having schizophrenia, having the less survival. And on an average, during our PG days, it had happened to be a favorite question that on an average, a patient diagnosed with schizophrenia has a shorter lifespan of around 15 to 20 years.
Yes.
So there are different attributes that have been mentioned due to their lack of insight, their lack of physical activity, comorbidities, metabolic syndrome, so on and so forth. So what is the current view of this reduced mortality, and what are the next targets that we, the psychiatrists of newer generation, can do?
So obviously this is a troublesome trend. I think there was an editorial in BJP around 10 years ago, 10 or 12 years ago, which was, I think it was that lady who was the editor, who was the president of the Royal College some years ago. And she made a very nice, not nice, she made a very tragic comment. She said the life expectancy of schizophrenia had been increasing with this 10 or 15 year gap, but it was parallel to that of the normal population. As the population was aging, schizophrenia were also getting older, but they were dying 10 years earlier. But in the last 5 years, at least in England, they had started dropping. I mean, the sense the gap had become larger than it was in the 60s and 70s. Okay. So this is where the history comes in again. So we analyzed the number of deaths, the number of mentally ill in the census of India. He's already mentioned my friend Alok Sareen. So we looked at the census counts. And in South India, in Southern India, in the great famines of 1878 and 1888, about 20% of the population died. But in the census of 1881 and 1891, there was a 40 to 60% decrease in the number of mentally ill. As the asylum doctor in the Mysore Mental Hospital noticed, the only people with schizophrenia, with mental illness to survive were those who were inside the hospital. Those who lived in the community did not survive because in times of famine, they were the least priority for anybody. The same thing happened in Philippines with the cyclone. Once the cyclone moved away, because Philippines and Indonesia have this tradition, because they don't have services, of tying patients to their beds or to shackles inside their houses. It's home care, but with a chain, which community psychiatry is quite happy with sometimes. So when the cyclones came, these people couldn't run away. So they died. So there are a lot of social factors in this recent increase. Now, having worked in a mental hospital, I know that some of our elderly patients would have died years ago had they been in the community. Nobody would have looked after their cancer. Nobody would have looked after their diabetes. Nobody would have got a surgery for osteomyelitis, etc., etc. Who will pay 2 lakh, 3 lakh rupees for looking after a person who has never worked in their lives? So in the last 5 or 10 years, this, to my mind, that's a very sad outcome of deinstitutionalization. Patients are living on the street. They are living impoverished lives. They are not getting medical help. They cannot access medical care. In America, they cannot be even insured. All this has impacted on the life span of chronic mental illness all over the world. In India, we have never measured it. There was one paper, I think, from SCARF, which said that it's about 18 years less. But this needs to be a constant effort. I mean, I was, again, since I'm nearing the age of retirement, and one of my patients, he was seeing me, so I put his age down as 45 or 50. He said, "Doctor, you saw me when you were a student, and you are retiring now. So how old do you think I am?" So then it struck me that in the OPD, if I go out, I don't see anybody of my age. I was seeing the same patients. I was seeing the same schizophrenia as bipolars from the time I joined as a resident. How come none of the patients which I saw then are seeing me now? They should have grown old in synchrony with me. But you go to any OPD in any hospital, there'll be very few patients with a chronic psychosis above 55 years of age. At least they're not there.
Thank you so much, sir. Thank you so much, sir. Dr. Chitramohan.
Sorry.
Thank you. Good evening,
Hi.
Sanjeev.
Hi, how are you?
Hi. I'm good, thank you. Thoroughly enjoyed the discourse. I just wanted to ask you a couple of questions. You have alluded to the fact that clozapine is superior to other non-clozapine antipsychotics in terms of its efficacy.
Superior.
In terms of its efficacy on treatment-resistant schizophrenia, it's the only licensed drug, and also maybe impact on negative symptoms and cognitive symptoms you mentioned earlier. My first question is, what explains clozapine's superior efficacy over other antipsychotic medications? And the second question is, we know antipsychotics are effective in relapse prevention. There are a number of meta-analyses and systematic reviews by Stefan Lloyd. Yet we all come across patients who are very well maintained on either oral antipsychotics with good adherence or long-acting injections with very good adherence. Yet there is breakthrough psychosis one sees.
Right.
And what explains that?
No, we've been worrying a lot, as like all of us. And I think we lost an opportunity in the 70s, 80s, 90s by our urge to get stuck with the dopamine theory and trying to invent drugs that are highly more and more specific to D2 receptor action. I think clozapine was invented in 1958 or 59, first time. And it was the dirty footprint of clozapine is actually much like thyroidazine and chlorpromazine. Okay, so I think dirty footprint drugs had a value because by putting too many eggs in the dopamine modulation theory, we tried to make more and more specific drugs and we only produce more and more tardive dyskinesia. We do not change the other aspects of schizophrenia. I think to understand this, we really have to understand which which components of the clozapine, its interface with serotonergic receptors, histaminergic receptors, cholinergic receptors, how many of them are contributing to which aspect of the response. And we haven't done that kind of study because we don't actually measure. We measure EPS very well, but we don't document anticholinergic effects that well. The constipation, the blurring of vision, what happens to cholinergic habituation, and what does the impact of cholinergic habituation on memory. We know cholinergic pathways are important for memory. And we also know that they habituate very differently. Constipation occurs very severely in some clozapine patients, so much so it's toxic, and some it doesn't. But we haven't merged these two fields. The adrenergic dysfunction, the orthostatic hypertension, the blood pressure variability, the cardiac effects. So right now, a group of our people is looking at cardiomyopathy genes. And we have a family in which 2 or 3 sisters share that cardiomyopathy gene. And they're exquisitely sensitive to clozapine. So when you give them clozapine, their heart has developed atrial flutter. So there is an interface between many other aspects of biology of clozapine that we don't understand. Whether it's membrane stability, whether it's ion channel excitability, and this is like a myosin chain which tethers some receptors. So there are many aspects of clozapine that we don't know. I think we need to, it is a long answer, but I think we need to step out of this dopamine, serotonin, ballet, and think of these as much more complex chemicals. And I think we'll find an answer if we look at it systematically.
Thank you, sir. Amit sir is there.
Thanks. I hope I answered it. Nice to see you after many years.
Good evening, Dr. Jain. I'm Amit Banerjee. I'm in Perth in Western Australia. I've been in Australia since '97. So really don't know the clinical scene in India anymore. But I have 3 questions, 1 clarification from you and 2 questions basically. You said a little while back that since the 1950s, we do not have any more new drugs. I didn't really get that. What exactly you meant by that, if you could clarify that.
So most of the first generation drugs were defined by varying the tricyclic structure of chlorpromazine itself. And then the moment you got into stereochemistry, then you realize that the conformational similarity, not simply the tricyclic structure on a 2-dimensional paper, but the steric symmetry of how they're going to bind to dopamine receptors was critical. So you developed all the butyrophenones and all the imidazolone drugs. And all the other drugs that we have developed have been variations on the same biology and molecules. So we have not had a conceptual leap in inventing a new drug. We have tinkered with the existing drugs of the 50s and 60s.
But what about drugs like clozapine and...
Clozapine was way back in 58 as a variation of the chlorpromazine molecule. So it's a very, very old drug.
Yeah, my questions, thanks for that. My questions are like, what about illicit drugs? And could you give us a comprehensive account or your understanding of the neurobiology of cannabis and its link with association with psychosis? That's one question. And the third, second question rather, I was going to ask you was about negative syndrome or symptoms. And what is your understanding of the biology of negative symptoms? To me, it seems obviously everyone knows that the problems of schizophrenia are negative syndrome schizophrenia. I really don't believe, I think we put too much emphasis on delusions and hallucinations. And essentially what clinicians need to understand is possibly, lack of insight, what reality contact, a person's touch reality. I know psychiatrists have been given this unique position in society to understand what reality is, or to determine, who is mad and who is not mad. But negative syndrome schizophrenia are the killer symptoms, and the and the neuropsychology, obviously in the prefrontal cortex, and executive functioning and the biology of executive functions is possibly the best way to understand them. So those 2 points about cannabis and then about negative symptoms. Thanks.
So cannabis and all are very, I mean, drugs of abuse are very interesting because for obvious reasons. Because if you read Professor Herbert Meltzer's account, all the drugs that we use in psychiatry are basically drugs that reverse the action of LSD, amphetamine, cocaine, etc., etc. So anything that reverses the action of drugs of abuse becomes an antipsychotic and antidepressant, and therefore there's an obvious need to study these drugs of abuse. But that gives rise to a number of intriguing fundamental questions in biology. So for example, dopamine, serotonin, and cannabis appear in plants several billion years before animals existed on Earth. So what do they do in those plants? Why have human brains evolved to use a metabolic transmitter in plants for getting high in their brains? Because the serotonin occurs in plants in actually all the way back to algae. So it's a very, very old very old chemical. Cannabinoids are as old. So these plant-based products seem to, number one, guided brain development. And after all, we must realize that as animals, our only job on Earth is to grow and propagate plants. We have no other role on Earth. We're only plant pollinators because they're too lazy to have sex themselves. So the only job of animals is to make plants fertilized. And 20% of the world's land is taken over by drugs of abuse. Tea, coffee, sugarcane, cocaine, cannabis. 20% of the plants of the land on Earth is taken over by drugs of abuse. Tea, coffee, cocaine, sugarcane being the classic examples. Why are these important? Because cannabinoids are lipid proteins and they get involved in membrane formation from the time of evolution of life on Earth. So it's a debate whether life began with membranes or with proteins, and people fight all the time. But cannabinoids are lipoproteins. They have one foot in the lipid camp and one foot in the protein camp. So they can get to places that other things can't. Now, so therefore the actions of cannabis on brains of all animals are exceedingly complex, but they're quite similar. Cannabinoid receptors are seen in C. elegans in earthworms to control feeding, control sexual behavior, control exploratory behavior. So endogenous cannabinoids therefore exist from the beginnings of animal life to control the same things. So we really need to understand drugs of abuse from therefore an evolutionary perspective as to what has been the role of these drugs in defining how brains arose and adapted to these toxins, what we now call toxins, in the world around us. So obviously we incorporated certain actions of these drugs to drive our brains and make our brains become adept at the kind of things that our brains do. Now, at the same time, because plants are much better at making chemicals, they can always trip you up. No matter how complicated and how many billions of neurons your brain has and how finely it is controlled, a simple few micrograms of cannabis, which is a byproduct of the fertilized flower of a cannabis plant, can trip your entire brain. So over-engineering has a problem. Plants are much better and they can trip your brain up anytime they want. So one should not get too vain about our Homo sapienness, which depended entirely on the plants. So cannabis and drugs of abuse therefore offer a window into understanding not just the biology of the brain, but the biology of how minds and brains get created in the first place. That is a much more fundamental question. And therefore, drug abuse research must focus into that comparative biology of how drugs of abuse are used by different mammals, vertebrates, different kinds of brains, different kinds of genetic variations. What is the match between receptor biology, receptor genetics, receptor proteins? Now, the fact that colleagues of mine in the UK point out that these designer drugs sometimes cause catatonia lasting 2 or 3 days. These synthetic amphetamines or synthetic cannabinoids, they can produce very severe psychosis and very severe hallucinatory phenomena. And all of us were taught that you can manipulate the structure of dopamine and epinephrine. So one amino acid shifted here, it becomes cocaine. Another place, it becomes amphetamine. But they are basically tinkering around with the structure of a dopamine receptor. So by changing the elements around it, you can produce a drug of abuse and then make it even more and more and more specific. So it's a very, very simple chemistry. Why do our brains allow such simple Achilles heels is a fundamental biological question. And we really have to understand this. So no matter how complicated or how good the brain is, it gets stripped by very simple molecules. Why should such a complex molecule structure have such blaring design defects? I have no idea. Perhaps it also increases variability. So brains that become tolerant to drugs, perhaps like all of us have become tolerant to tea or coffee. It was viewed as a neurotoxin 300 years ago. I think the British king's trying to ban it because of the detrimental effect on the brains of their citizens. But no, none of us can even work without tea or coffee. So it's a complex. I mean, it's more complex than I would like to think. So it's really quite troublesome.
Thank you, sir.
Amrit, there are too many questions. I think if we can request,
we cannot take any more questions.
Yeah, we request him, sir. Can we request you to come once again?
Sure, sir.
Because too many questions are there and very good questions, but
so we'll send the questions to you, sir. So we'll send the questions to you in the mail, and maybe we'll take up those questions in next.
I'll try my best to answer in a writing form, but it's much easier to chat. But I think we've been at it for 90 minutes now.
Yeah,
we'll chat once more.
So we'll chat once more, sir. That's
over to chairperson, sir.
Thank you so much.
Dr. Mohan Raj, you want to say something?
No, I really enjoyed. It was like a ward rounds with Dr. Sanjeev Jain.
Oh,
that's one. And like as everybody said, there are a lot of questions, and we need to do more. That's what I wanted to say. Really enjoyed the session.
Thank you, Mohan. I've been enjoying your photographs and your comments and various forums.
Thank you.
Anyway, Dr. Sanjeev Jain, though he has told that he will answer philosophically or technically and all the things, everything he starts technically and ends philosophically. There are two take-home messages which I am taking as that there is an evolutionary benefit in keeping the schizophrenia in the world. That is one. Next is the golden months of treatment of all modalities, not just antipsychotics. These are the two take-home messages which I am taking today. Thank you very much, Dr. Sanjeev Jain. And thank you very much for the organizer, Dr. Topati, for making me chair this such an interesting session. We are looking forward to the next session, continuation of it. Thank you.
Thank you. So obviously there's evolutionary significance for psychiatrists also. So perhaps we can say that we need to exist.
Provided we go into the molecular level inside the cell, and molecular psychiatry is developed not only in humans, all over.
Right.
Yeah, inside the cell is the keyword, I think.
Yes.
Yes, inside the cell is the keyword, and molecular psychiatry. We are thinking that we are biological psychiatry. That is too big a term. We should be molecular psychiatrist.
Absolutely, man. Tufan, sir.
Thank you, Dr. Sanjeev Jain. Thank you
Before Dr. Tufan, can I thank Dr. Tufan Bhatti, Dr. Aleem Siddiqui, and Dr. Amrit Pattajoshi for this wonderful series.
Okay.
Thank you.
On my behalf also.
Thank you, dear Mohan Raj. Thank you so much. Sure. About my comments, when I heard of the topic, it fascinated me. It reminded me of Lord Tennyson's The Brook.
Right.
Men may come and men may go, but I go on forever.
Exactly.
And that is why I wanted to talk to Dr. Sanjeev Jain personally. Maybe to my misfortune, his free time and my free time did not coincide. And I could not talk about this lecture, but I was well informed by Dr. Lim Chindeki about the schedule and what is going to happen. I enjoyed the talk very much because I enjoy puzzles. I tried 500, 1000 piece puzzles, I enjoyed. And this was quite immensely enlightening and immensely puzzling also. I realized that in spite of the enormous scientific advancements in all spheres which has been reflected upon by Dr. Jain, we are still ignorant to a great extent. And that is why we are in a position, not in a position to decide properly about the real dynamics inside the circuits, inside the cells, not only for psychiatric disorders, but also all disorders, because in some plane they appear to be connected with each other, because it is the one human being. There are advancements in botany, genetic engineering of plants. There has been development like genetic silencing, but all these things do not provide an answer. And we are, like Alim told in the beginning, definitely I shall run through the program very slowly and try to really see what I have imbibed. And we would love to have you again.
Pleasure,
Post
sir.
the questions.
Pleasure.
Treat it up as you like. And because it will be really enjoyable.
Thank you. Thank you so much, sir.
I confessed it was puzzling to me, but I enjoy puzzles, therefore I enjoy the talk from beginning to end. Thank you, Dr. Zain. Thank you so much.
Thank you. Thank you.
Amrit, over to you.
Sir, on behalf of the IPS Odisha State Branch, I would like to give a formal thank you. Sanjeev boss, you were amazing. You know, the interactions, the way you didn't take any sides. The best part about it, you just didn't talk about molecules. You just didn't talk about biology. You also talked about the interactions. You also talked about psychology, which actually, we are having a lot of debates, fights regarding this. And finally, it's not as simple as it is, but it's not as complicated as it is also. That's right. The thing I could get. Saranya madam, told the take home points. Mohan sir has been, like elder brother, he has been very, very cool, quiet, and thank you for that, sir. We had today a lot of amazing young, researchers who have the inquisitive mind, who came out with the questions. And I thank everybody for joining in and asking the questions. A lot of people across the globe also asking questions. Questions were, all very, very related, very, very important. And Dr. Sanjeev Jain did a wonderful job about it. As Dr. Alim and Dr. Tufan was telling, it requires much more time than this 1.5 hours to get things into our mind. And I hope we'll replay all these videos of me. And today's video should be a collector's video. That's what I feel it is. And thank you everybody.
Thank you.
For joining in. And we had more than 350 attendance, a peak of 247, and that's a great thing, sir. When webinars, people are having webinar fatigues, people coming in, joining in, it's more molecular, not biological, as ma'am was talking about. That's amazing. And our organizers, the Torrent people, one of them had an emergency at home, somebody died. He managed to, even from there, he managed to get in the logins and all at 7:45. And we would, thank you for those efforts. Thank you for everybody for logging in. We will have Dr. Sanjeev Jain again, maybe in the next 1.5 months, with all these questions.
Our apologies to the people whose questions we have missed.
No, we'll take up the questions, Ali. No apologies. We'll take up these questions.
I propose we'll send all the questions to Dr.
And then we make a presentation
so that he can collate it to different divisions.
So
it will be more interactive.
If I can make one closing, when I was finishing my medical studies, whatever, 1980, one book came out called The Encyclopedia of Medical Ignorance. Big fat book. Big fat book in the library. So what are the fields of medicine that we know nothing about? And what are we in? So it's a textbook of medical ignorance, which is a wonderful title. So I picked it up. But 30% of the book, 1/3 of the book was about psychiatry. Because even for cancer and for leukemias, the intellectual models were there. It was mainly a question of technology by 1980. And now myeloma, leukemias are straightforward diseases. You can just treat them like that. But medical ignorance for mental illness is really very high. It has not changed very much in 40 years. So it's really time because you made that comment about young people. So it's very, very important that young people get into solving this ignorance. It is complex.
The decade of the brain will take care of it.
No, we are in the third decade of the brain, madam. Out of the last 40 years, we spent 30 years.
Some more researchers are going to study more and more.
So that's
not
why.
brain, the molecules of the inside the cell.
Right. So it's very.
And I would take this opportunity to also thank Dr. Bhaskar Mukherjee, who has guided us in this whole endeavor. So
I didn't see him. He's very quiet today.
He logs in another mobile, sir.
Okay. Okay.
So thank you, everybody. Good night.
Thank you
Hope
so
to
much.
see you on another Thursday music. Good night, sir.
And thank you, Ali.
Thanks, everybody. Good
Wonderful
night.
job. Thank you, Tufan sir.
Thank you. Thank you,
guys.
thank you, madam.
Thank you.
Thank you, ma'am.
Thank you very much.
Sir, Sanjeev sir.
Thank you.
Bye-bye.
Mohan Raj.
Bye-bye. Good night.
Both the chairpersons acted instantly. I am very much obliged.
Absolutely. Bye-bye.
Thank you, sir. With your permission, we can close the meeting.
Yes. Yeah.
Yes.
Thank you. Thank you.
You are the host.